beyond compliance, creating role clarity through training needs analysis in hospital security. Today's speaker is Simon Whitehorn. Hi, Simon. Thank you for joining us.
Hi Matt, how you doing?
Good, sir. Could you share us a little bit of your background, please? Just give us a bit of an introduction before we get into the webinar.
Yeah, sure. So I am one of Maybo's lead consultants, and I look after all of our healthcare clients, pretty much, certainly in the UK. My background before I came to Maybo was managing healthcare security teams. I was a violence prevention reduction specialist in the NHS in England, and a hospital security manager. I managed training teams, training conflict management, conflict resolution, physical intervention training across a couple of acute hospitals in the NHS, and also across a mental health trust in the NHS in a large city centre in the UK.
Awesome. Thank you very much, sir. I suppose jumping straight on to then exploring a bit of your experience, your background, and with what you do now. Looking at TNAs, can I ask you first, starting off with hospital security, what is different with a hospital security officer's role compared to other security environments like shopping centres and office buildings?
I think it's probably the hardest place to be a security officer. It's probably the place with the most diverse interactions, and it's probably unique in compared with those other locations you talked about, in the fact that most of the other locations you talk about, people want to be there.
Mhm.
By definition, most people probably don't want to be in hospital. Popping down the shops is something that most of us probably look forward to, or at least put up with. Ending up in hospital is something that probably leads to it being, or is associated with lots of negative emotions. It's probably somewhere we don't want to be. We often, unless you're perhaps there because you're having a new addition to the family, often we associate being in hospital with negative experience. Either we're in pain, we've done something to hurt ourselves, we're worried about something, about our own health, or the health of someone that is important to us. So I think that adds a whole level of stress, of fear, of anxiety, of worry to everybody before they even arrive at the building. People who work in healthcare, we get very used to being in that hospital environment. It becomes our normal environment, but it's very far from a normal environment for most of the people who were there. I think the other difference for me is around the role. Often security officers are involved in managing people's attendance at those places, and a lot in shopping centres, for example, you can be asked to leave if you're in a pub or a club or a venue. You can be asked to leave if you perhaps are not following the expected rules of behaviour in that premises. There will be circumstances where people can't be asked to leave the hospital, and there will be certain circumstances where their behaviour is not perhaps fully under their control, and their behaviour is linked to their clinical condition. That, I think, is what makes a hospital unique from a security point of view.
You're starting to touch on some of the challenges that would be really good to have a bit more of a dive into. What are some of the real challenges for security officers in hospitals when it comes to detaining and removing patients? I suppose expanding on what you just started to touch on. Um, yeah, that's unique to hospital settings.
I suppose there's the two bits, Matt. There's we will see people who perhaps clinical staff would like to leave, either
Okay.
because their behaviour is inappropriate or has been inappropriate. Perhaps they've reached the end of their treatment options. Perhaps they've presented at the wrong health setting, for example. Perhaps they just need to go to a pharmacy, for example, and they've rocked up at an emergency department or emergency room and are asking for treatment. Perhaps they've had a series of investigations, and actually there's nothing wrong with them. There's nothing that the hospital can treat at that point. It might be that they're there because they are street attached or homeless and are finding somewhere warm, dry to shelter in the winter, and for whatever reason they need to, or they have been asked to leave. So you'll get security officers asked by clinical staff sometimes to remove people from the premises. That's fine if it's clearly obvious why that person might be asked to leave, but it puts the pressure on the security officer potentially, because they're the person who's doing that removal. They're going to be the person who is ultimately responsible for that person leaving a nice warm building and going outside at 3 o'clock in the morning on a cold, wet, rainy Saturday night, where there might not be other support available to them. So that puts the pressure on the security officer to do that, and make that decision and justify that decision, because it's ultimately their decision. They're going to have to justify the outcome of that if something goes horribly wrong. And we've seen stuff go horribly wrong in healthcare where those decisions are made. So there's a bit about the security officer having to understand that decision, and that decision have to be justified to them before they can do it. I think the other bit is we will be asked potentially as hospital security officers to stop people leaving, or encourage people not to leave, because those examinations, those investigations haven't finished, because doctors want to do one more scan, wait for one more set of results to come back, or an individual needs perhaps a mental health assessment for their fitness to leave the hospital. And again, that can be quite clear cut, and security officers can look at that individual and make a decision and go, you know what, actually, I think I can intervene here and justify my actions because they're necessary, proportionate, reasonable, or there's a clear legal boundary, legal grounds for stopping that person leaving. But there can also be options where maybe that individual, hospital staff would like them to stay, but that individual is saying, I want to go home, and he's making clear, cogent reasons for why they should go home, has the means to get home, has the means to get in, is maintaining that they're quite safe at home. They come back in and see the doctor, or they'll go and see their own doctor the next day. So then it can be a really difficult decision for the security officers to prevent that person leaving. Ultimately, we could be talking about having to use physical force to stop someone leaving, and that decision can be a really difficult one to make.
I suppose looking at that dynamic between the clinicians and the security staff, and some of my experience working in those settings, it's often a challenge around clarity on who's doing what and when, and who's telling what to do. And so, can you help me understand when it comes down to the TNA, how could a training needs analysis, how could the TNA process help, or can it help clarify roles between clinicians and security staff?
Yeah, I think absolutely, Matt. I think that for me is the fundamental part of the training needs analysis, and maybe I've got an online training needs analysis tool that people can use to help identify what training they might need or their teams might need. I think the benefit of a clear training needs analysis is it's looking at what are the expectations on those individuals. What do we want those people to do? And if we're clear about what we want those people to do, those people can be clear about what their role is with other people. It's really easy then to communicate to clinical staff, perhaps who have a misunderstanding or perhaps would like security officers to do more than they're perhaps able to do, and vice versa. But it's about that clarity of understanding precisely what my job is. If that's documented somewhere, there's no arguments about what that is. Historically, we've seen, I think, certainly in the UK in healthcare, a bit of a lack of clarity over exactly what is expected of security officers. So anything that establishes that clarity, I think, is to be welcomed.
I understand in Mavo, so what we'll do a lot of the time is focus on what staff need to do rather than what staff need to know. We focus on scenarios. So let's say going through that TNA process, when we identify roles and responsibilities, and then we've got scenarios in there, what are some of the benefits you've seen to training security around scenarios that they're likely to be in, as opposed to sort of generic blanket training?
I think that's the key to making the training realistic, Matt, for me. We know that actually if we train people with the types of incidents, the types of scenarios, the types of things they're going to experience, it makes it relevant for them. It makes it real for them, and it cuts through some of this stuff we often get with training. Is yeah, but we don't quite do that. Yeah, but that's not what we do. Yeah, but that's never going to happen here. So if as part of the TNA process we've identified those 3 or 4 perhaps key scenarios, 3 or 4 types of incidents, 3 or 4 types of people we have to, or behaviours that we have to respond to. then we can be really clear that the training meets the needs of those staff. And that's fundamental for me.
I suppose sort of a last question I've got is, from your experience working with hospital security teams, looking at TNA, creating scenario-based training, are there any other wider benefits that you've seen to involving the clinical team and security team in the TNA process? Like, are there any other wider gains to be had around, like, who takes accountability for content that's been included in a program? What are some of the other benefits that you've seen when you bring those two groups together in a TNA?
I think bringing the two groups into TNA is the first part, Matt. I think the real benefits come from, and we sort of touched on that a little bit about role understandings and expectations. I think the real benefit comes when we go for the next stage and say, actually, let's look at that joint training. And the joint TNA or a jointly developed TNA leads us to that, because it enables everyone to see, well, this is the training that security officers have had. This is how it interacts with the training that the clinical staff have had. And does it match? Is it the same thing? Are the same messages running through that training? It's not to say that, example, again, in the UK, we've got the Mental Health Act, and there are legal provisions in there that apply to certain sectors that facilitate doctors being able to do certain things and detaining people, ultimately depriving people of their liberty. Now, security officers don't need to know all the ins and outs of that, but they do need to know enough about that to be able to support the clinical staff in those decisions. And clinical staff need to know that security officers know enough about what they're being asked to do. And that's some of the things we were talking about earlier on. And I think it's really important, but we see so much better engagement. We see so much better teamwork, particularly when, potentially the security team are provided by a contractor rather than being part of the employed team of the hospital. There's a whole other chain there going on of instant reporting, potentially, of who's established what the training is. And if we can bring that together and make sure that we've got joint understanding of the role, joint understanding of training for that role, and in an ideal world, joint training, I think that all that's going to do is promote better understanding, better communication, and ultimately a better service delivered by the security team for the clinical staff, but ultimately for the patients of that hospital. And let's not, we've spoken a lot, I've spoken a lot about emergency departments, but let's not forget hospital security officers are spending time in lots of different wards as well. Often the perception is that incidents of violence, of aggression, of challenging behaviour, whatever label we choose to put on those distress behaviours, because that's often what they are, only occur in the emergency department. Frequently they don't. Frequently they'll be occurring in the wards and areas where we're looking after people living with dementia. They may well often occur in the areas where, again, because in the UK there's a pressure to move people through the emergency department in a timely manner. That might mean they're moving to an assessment ward. Well, that might lead to behaviour being displayed there. We often see in the UK wards where individuals who perhaps have often the gastro wards, it will be where we see issues, because that can sometimes be where individuals with issues around addiction to alcohol can end up going through to. Then by the time they've reached that ward, they may well be starting to detox from their alcohol addiction, and that might cause their behaviour to become quite challenging and difficult to manage. So while we talked a lot about emergency departments, this isn't just about the emergency department. And I think that's part of the benefit of TNA, of looking at what groups of patients is it the security officers are likely to encounter, what areas of the hospital is it they're likely to encounter those, and what things are we going to expect them to do. So it can be quite a long process, but I think we can shortcut it because we know those scenarios, we know those types of incidents, we've got experience of working with them. So let's focus on those needs and hopefully deliver a training package that meets the needs of everyone, patient, staff, and security officers supporting them both.
Super useful. So I really appreciate your thoughts on that. That's where we're going to wrap up today. But I'm going to put out your email address at simon@maybo.com if anybody wants to reach out to you to look into exploring some of the TNA process for hospital security staff. No doubt you'll be happy to take their call.
Absolutely, Matt.
Thank you very
Lovely.
much, Simon. Really
Good to
appreciate
speak to
your
you,
time.
mate. Speak to you soon. Cheers.